Today, we're basically stepping into the shoes of a medical detective. We're going on a journey into the systematic, step-by-step investigation that doctors use to evaluate the human heart. It's this absolutely fascinating process of decoding clues, interpreting symptoms, and avoiding some very common pitfalls to arrive at a life-saving diagnosis. Let's get into it.
To really understand why this detective work is so incredibly critical, we have to look at the sheer magnitude of the crisis. 19 million. That's the estimated number of deaths globally from cardiovascular diseases every single year. Just to put that into perspective, in the US alone, we're looking at nearly 700,000 deaths annually, and about a third of those are completely sudden. It's literally the most prevalent serious disorder in industrialized nations. We're talking about a true global health emergency.
And you know, the face of this crisis? It's changing. For decades, cardiovascular disease was kind of brushed off as a man's disease. But look at the shifting demographics. While age-adjusted death rates have actually dropped significantly for men over the past 40 years, the absolute number of deaths has been rising in women. Why is that? Well, the data suggests that things like inflammation, obesity, and type 2 diabetes play a much more prominent role in developing coronary atherosclerosis in women. Plus, women more frequently experience dysfunction in the heart's microcirculation, making it a distinctly different and absolutely vital puzzle for us to solve.
Okay, let's dive into this. To make sense of such a massive topic, we're going to follow a clear, logical, clinical pathway. We'll start with the global heart crisis, move into decoding common cardiac symptoms, explore the 4 diagnostic pillars, check out modern medical detective tools, look at how to avoid common clinical pitfalls, and wrap up with smart management and prevention.
Section 1. The Global Heart Crisis. Section 2. Decoding Common Cardiac Symptoms.
So when a patient walks into the clinic, their symptoms are the very first clues. You can kind of think of this as the initial crime scene assessment. And to really understand these clues, let's use a brilliant analogy. Think of the heart like a house. When there's an imbalance between the heart's oxygen supply and demand, that's ischemia. It's like a furnace just not getting enough fuel, and it shows up as chest discomfort. Now, if the house has a plumbing issue where the main pump fails, fluid backs up, right? That causes fatigue, shortness of breath, and swelling, or edema. Then you have obstructions, like a stuck door. Valvular stenosis is a great example, and it can actually mimic that pumping failure. Finally, arrhythmias. These are the house's electrical glitches, causing sudden palpitations, blood pressure drops, or fainting spells that just appear and disappear out of nowhere.
But you know, a symptom by itself, it isn't enough. Context is literally everything. A heart might function perfectly fine while you're sitting on the couch, but completely fail when you're walking up a steep hill. Because of that, symptoms like dyspnea or chest discomfort that flare up during physical exertion are your classic red flags for heart disease. On the flip side, and here's an incredible insight for you, if symptoms appear at rest but actually go away during exertion, that is rarely caused by a cardiac issue.
And this is exactly where the detective work gets kind of tricky. The human body is full of red herrings. You constantly have to ask, is it the heart or is it just anxiety? Shortness of breath could absolutely be cardiac, sure, but it could also be lung disease, marked obesity, or simply a panic attack. Edema, that swelling in the legs we talked about, might be heart failure, or it could be untreated kidney or liver disease. Syncope, fainting, could be a dangerous cardiac arrhythmia, or it could stem from a purely neurologic issue. It takes really careful medical sleuthing to separate the actual cardiac signals from all that systemic noise.
Section 3. The 4 diagnostic pillars.
Once we've gathered all those initial clues from the history and physical, we need a framework to actually process them. So the crucial point is this: just figuring out someone has ischemia isn't the end of the line. Doctors use the New York Heart Association's structured framework to build a complete diagnosis. It's a 4-step checklist. First, what is the etiology or the root cause? Is it congenital, hypertensive, ischemic? Second, what's the anatomy? Which specific chambers or valves are affected? Third, what are the physiological disturbances, like arrhythmias or heart failure? And fourth, what is the patient's functional disability? Meaning, how much does this actually limit their everyday life?
To answer that fourth question, clinicians rely on the NYHA functional classification breakdown. It's a really essential way to quantify exactly how disabled a patient is. A patient in Class 1 has no limitations at all. Ordinary exertion doesn't cause any symptoms. Class 2 introduces slight limitations, where ordinary activity starts causing issues. Class 3 means marked limitation. Even less than ordinary activity causes symptoms, though they do feel fine at rest. And finally, Class 4 is severe. The patient literally cannot carry out any physical activity without discomfort, and symptoms are present even when they are sitting perfectly still.
But here's the catch.
Quantifying that disability means you really have to know the patient's baseline. Context matters so much here. Think about it. If a patient tells you they get completely winded after walking up 2 flights of stairs, your reaction has to depend on who they are. If a highly conditioned marathon runner suddenly develops 2-flight dyspnea, that is a massive, alarming clue of functional impairment. But what if you hear that exact same symptom from someone who has been completely sedentary for 10 years? It carries a very, very different clinical weight.
Section 4. Modern Medical Detective Tools.
Now, while a careful history and physical exam set the foundation, doctors today have an absolutely incredible toolkit to gather hard evidence. This includes the ECG to check electrical rhythms, though, quick side note, ECGs have a very wide range of quote-unquote normal, so they always have to be interpreted in context. Then we have non-invasive imaging like echocardiograms, CTs, and MRIs. There are blood tests to check lipid levels or heart failure markers like BMP. We have invasive procedures like cardiac catheterization. And increasingly, we're using genetic tests to pinpoint inherited disorders like prolonged QT syndrome.
Now, what's really fascinating about clinical algorithms, like the one used for evaluating a cardiac murmur, is how these tools are applied systematically. The whole goal is so we don't overtest. For example, if you have a soft, mid-systolic murmur in a young, asymptomatic adult with a normal ECG and chest X-ray, the algorithm usually points straight to no further workup. It's almost always benign. But if that murmur is loud, or if it happens during diastole, the algorithm mandates you get an echocardiogram.
And that is because a murmur isn't just a sound, right? It's literally a window into the physical flow of blood. By systematically evaluating its timing, duration, intensity, and location, the clinician gets a direct acoustic map of the heart's internal plumbing. And that acoustic map acts as a highly precise guide, telling the doctor exactly which high-tech tool they need to pull out next.
Section 5. Avoiding common clinical pitfalls. But hey, even with the absolute best tools in the world, human error is still a thing. In modern medicine, increasing subspecialization can actually create some really dangerous diagnostic blind spots. Let me give you an example. A non-cardiologist treating a stroke patient might completely miss the fact that the root cause was a structural heart defect, like a patent form in a valve that threw a clot. On the flip side, a highly specialized cardiologist might see a patient with a fluctuating atrioventricular block and fail to realize that the true culprit isn't even primarily cardiac. It could be a systemic illness, like Lyme disease. Which brings us to a really powerful rule of thumb regarding our reliance on all this invasive tech. To quote the source text directly, a coronary ardiogram should not be performed in lieu of a careful history. These highly invasive, really expensive tests, which, by the way, carry their own risks and discomforts, they must supplement, never supplant, the fundamental clinical interview. An angiogram can definitely show you an obstruction, but it often cannot definitively answer if that specific obstruction is what's causing the patient's exact symptoms.
Section 6. Smart Management and Prevention.
All right, which brings us to the final phase, closing the case. Managing cardiovascular disease follows a very strict logic. First off, if an examination shows no evidence of heart disease, you have to clearly reassure the patient. You don't want them developing crippling medical anxiety from unnecessary overtesting. If they do have risk factors, we aggressively target things like weight, smoking, and hypertension. For patients who happen to have anatomically severe valvular disease but feel totally fine, we don't just rush in. We track them with periodic evaluations every 6 to 12 months so we can catch any deterioration before it actually becomes disabling.
And the golden rule here? Treat the patient, not just the angiogram. The source material heavily emphasizes restraint. Just because someone has chest pain or a scan shows a narrowed artery, that shouldn't trigger a reflexive decision to just rush into surgery or place a stent. Mechanical interventions are reserved for very specific cases, like acute coronary syndrome or multivessel disease with left ventricular dysfunction, where the data actually proves it improves the natural history of the disease.
So as we close this case file, I want to leave you with a thought. Today we have genetic testing, advanced MRIs, robotic catheterizations, you name it. But as we've seen through this entire systematic approach, if we fail to understand the exact context of a patient's symptoms, all of that technology can easily lead us astray. So I'll ask you this, in an era of advanced cardiac technology, is our greatest diagnostic tool still just the simple art of listening? Thank you for joining me on this explainer, and keep asking the right questions.